Assalamu alaikum. Today we are discussing a case of laparoscopic pyeloplasty. The steps are the same: mobilization of the colon, and then identification of the ureter, and then dissection of the renal pelvis, and of course then is the ultimate procedure as the pyeloplasty. So we are mobilizing the colon now. The principles of pyeloplasty need to be discussed. Topmost is the vascularity. As we all know that the ureter does not have its own supply, it draws small vessels from its surroundings, and when they come near to the ureter, they run along the longitudinal axis. So the periureteral sheath is an important thing to preserve during dissection of the ureter and preserving its blood supply, because if the ureter becomes ischemic, there is a fair chance that pyeloplasty will fail. So it is the topmost priority in any reconstructive procedure. Second is anastomosis without tension. Do not cut the ureter or the pelvis so much so that then they are difficult to be opposed. So if they are difficult to be opposed, and after anastomosis, the anastomosis will be under tension and the blood supply will be compromised because of the tension, and hence the procedure will fail and there will be recurrence of the PUJ obstruction. Then the anastomosis must be watertight, because any leak of urine from the anastomotic side would lead to inflammation, because this is urine, and this inflammation will incite more inflammation, and hence by the end this inflammation will heal by fibrosis, and thus the PUJ will be stuck in the fibrosis once again. So the reconstruction may fail, be that a continuous or interrupted suture, but it has to be watertight. Then anastomosis of the ureter must be performed at the dependent portion of the pelvis, because we all know that there is a congenital condition called high insertion of the ureter, where it may present as PUJ obstruction. So anastomosis should be in the dependent area, so that the gravity may also help, and the urine can then move from the pelvis into the ureter. So it has to be implanted in an area which is dependent. The fifth principle is free drainage. Free drainage can be achieved through a degestant or a nephrostomy tube. However, degestant is preferred because it is internal drainage, and the catheter needs to be placed as well. This free drainage is needed for a minimum of 72 hours, because the inflammation will start subsiding in 72 hours, and then the epithelium is usually covering the area. So it gets sealed, and the edema subsides, and thus the free drainage will help. Redundoplasty is not of a principle. However, they say that if there is a huge pelvis, it is better to reduce it, because at times the huge pelvis it in itself it compresses against the structures and gets itself obstructed. And is usually the huge pelvis is also hypotonic, so the volume of the pelvis may be reduced. This is the crossing vessels, which are causing external compression on the pelviureteric junction. And the most important thing is the excision of the pathologic segment. So if you do everything, you follow each and every principle, but you do not resect the pathologic segment, there is a fair chance that the pyeloplasty will fail. So pathologic segment has to be excised. Here you can see that we have identified ureter, and it is doing its peristaltic activity, and we have to preserve the blood supply. You can see small vessels crossing here and there, but we are coagulating those vessels away from the ureter, preserving the small vessels which are running longitudinally along the ureter within the periureteral sheath. So the main principle here, when there is an external compression by the vessel, is that you have to dissect the ureter away from the vessels rather than dissecting the vessels away from the ureter, because like this is highly unacceptable, because doing that one can easily injure the vessel. However, the ideal position is this. But this is the correct way. Do not disturb the vessels and try to steer away the adhesive tissue from the wall of the ureter. And it is such a delicate maneuver that one should not denude the ureter. The periureteral sheath must remain over the ureter, because, as mentioned earlier, there are longitudinal vessels along the ureter. So the periureteral sheath needs to be preserved. The ureter must not be denuded, and at the same time the tissue needs to be dissected away from the ureter rather than from the vessels. And any injury to the ureter can be compensated for by repairing it or by excising it. However, a small injury of this vessel may lead to compromise of the renal parenchyma. In this case, maybe the whole posterior surface of the kidney, because these are the vessels which are providing blood supply to the posterior aspect of the kidney. Some people call them aberrant vessels. Actually, they are not aberrant vessels. This is just an early division of the renal artery into anterior and posterior branches. Since there is early division, so the branch to the lower pole and the posterior surface, it runs across an area where the pelviureteric junction is lying. And the other thing is that the other factor is that the pelvis is usually large and extrarenal. So both these factors lead to PUJ obstruction. Now here you can see that the lower portion is mobilized enough. Now we are mobilizing the pelvis away from the vessels. As you can see that the peripelvic tissue is getting dissected away. The blood supply to the pelvis must also be preserved. As you can see, there are vessels running along the pelvis. However, we are dissecting this fibrotic tissue or adhesive tissue away from the pelvis so that it is detached from the vessels. Enough mobilization below and above the vessels need to be achieved before the pelviureteric junction is cut and then delivered anterior to the vessels. So there are types of pyeloplasties, membered pyeloplasties and dismembered pyeloplasties. And so far, the dismembered pyeloplasty, that is Anderson-Heinz pyeloplasty, has the most promising results of all the pyeloplasties. And the reason behind that is that all the principles of pyeloplasty are followed in Anderson-Heinz, and the disease segment is also excised. Now, after enough mobilization, we are dismembering the ureter from the pelvis. Here there is some tissue along the ureter, so spatialization is performed. We need to spatulate it, and we need to spatulate it enough that here you can see that it is coming to the pelvis without any tension. So we spatulate a little more because here we don't think that there is any adynamic segment. So we are not excising that pathologic segment. So we spatulate it more towards the normal ureter so that if there is an adynamic segment, that is undone. Mobilization of this portion of the pelvis is of utmost importance, because the more we mobilize it, the more it will go away from the vessels, and tension will also be released. In the anastomosis can be performed without tension. Here you can see that I am not cutting the inferior segment of the pelvis, and we have excised. So we excise a little more just to reduce, but however you can see I am cutting again the area from the upper portion of the pelvis and leaving the lower segment behind. Here you can see that we can very easily come across this segment. The length of this segment is extremely important. You should not cut it like this, otherwise ureter will be anastomosed very near to the pelvis, and when you leave it, the ureter will go and get stuck to the lower pole of the kidney. But here you can see that the length is enough. Even if we release it, it is not getting stuck to the lower pole. So in secondary PUJ obstructions or the pyeloplasties that I have seen which have failed have been because of resection of this segment of the pelvis. So the multiple factors come into play then. So first one is the anastomosis is usually under tension. Number one. Number two, this tension leads to ischemia of the ureter. And when there is tension, there is a tendency that we have to mobilize more of ureter. So mobilizing more of the ureter leads to more ischemic injury. These are factor number 3. And factor number 4 is after anastomosis, when we leave the ureter and the pelvis goes towards the renal hilum, so it gets stuck to the lower pole. So far as the type of anastomosis, as I already mentioned, some people like interrupted anastomosis. However, I'm fond of doing continuous anastomosis. If it is interrupted, it has to be watertight. Interrupted sutures are better for maintaining the vascularity. However, it is difficult for them to be exactly watertight. So there is no harm. It is just personal preference. Whichever you like, whichever you are comfortable with, whichever you are expert in, you should follow that. So I follow continuous anastomosis, even if it is a small pelvis, even if it is a narrow ureter, even if the anastomotic area is very small. I always go for continuous suturing. However, I said that interrupted suturing is also acceptable if it is watertight. So talking about the free drainage, preferably nowadays degestent is the method of choice to provide free drainage. So there are advantages with the degestent. Number one, it is an internal diversion and patient does not have to carry any bags externally. Number two, it is bridging the anastomotic area. As we all know that manipulation surgically would create edema of the anastomotic area for a minimum of 72 hours. So during that period of edema, there is a chance that this area may get obstructed and the anastomosis will be disrupted. There will be urinary leak, and hence the pyeloplasty may fail. So during that period of edema, if we place a stent, that stent is usually helpful. As we all know that there is a reflux of urine when the DJ stent is placed, so we need to catheterize the patient for that initial period so that free drainage is achieved. The DJ stent is usually removed 4 to 6 weeks after the reconstructive procedure. However, the catheter can be removed after 72 hours. This again is a debate of preferences, personal preferences. I usually follow in open surgery. I remove the catheter after 48 hours to see if there is any leakage, and then I observe the patient for the next 24 hours. If there is no leakage in the drain, then I remove the drain on the third post-op day and send the patient home. And then I remove the DJ stent after a month or 45 days, that is 6 weeks. However, in laparoscopic pyeloplasty, as I perform this transperitoneally, so the preference here would be to remove the drain as soon as it is dry. Usually takes 24 to 48 hours. And then I keep the catheter for a minimum of 1 week, because any leakage transperitoneally can be cumbersome. Now here you can see that this is the way of placing the DJ stent. I use a 2 millimeter port for placing the DJ stent, and in this case I placed that 2 millimeter port in the already placed 5 millimeter port for liver retraction, so I did not have to create any other hole. And I place the stent and push it completely into the bladder, and then when the guide wire is removed, it is easy to push it into the pelvis and then pull from the bladder side. Now we begin the other wall. So, speaking of the anastomosis, I prefer continuous suturing because it is good for the anastomosis to be watertight. And for that watertightness, I keep the catheter for a minimum of 1 week, or preferably 10 days if possible. Of course, prolonged catheterization has got its own demerits. You can make a C and then place the needle holder in the center of this C, and then you make a knot, then another C, another knot. This first stitch is usually important and is also difficult. Once this first knot is taken, the rest of the job becomes easy. Care must be taken not to take the stent in the stitch. because we have seen a few cases where stent has been taken into the stitch, and then at the time of removal of the DG stent, one only knows that it has been stitched, and then it becomes a big problem. Then we remove it through a percutaneous procedure. But even then, if it is taken in the stitch, it is embedded in the mucosa. At times needs another surgery that may be open or laparoscopic. So fine stitches from the edges are taken. You can see the ureter very clearly, and you can also see that the periureteric tissue is preserved, and there are longitudinal vessels running in the periureteral sheath. In cases where the adult pyeloplasty is performed, it has been noted that 30 to 40% of the cases they have crossing vessels. So while performing pyeloplasty, especially laparoscopically, one must be mentally prepared to encounter a crossing vessel. And when it is encountered, principles have already been discussed. Dissect the ureter and the pelvis from the vessel rather than dissecting the vessel from the ureter or the pelvis, in which case there may be injury to the vessel, and the whole of the procedure will become a mess. So when the compressing vessels are encountered, literature says that in 60 to 70% of the cases there is no intrinsic factor or adynamic segment. The only pathology is the crossing vessel. However, literature also says that 20 to 30% of the cases do have an external factor like a compressing vessel, and an intrinsic factor as well in the form of adynamic segment. And the cause for failure of pyeloplasty in such cases is usually not excising the pathologic segment. So pathologic segment must always be excised as a general principle of dismembered pyeloplasty. However, you can see that we did not excise any segment, but we have addressed that segment just for an extra cautious care that you can see here. This you saw, yes, this one, the longitudinal vessel and the periureteral tissue. So we were discussing the excision of the segment, disease segment. So here we did not resect any disease segment. However, we addressed it by spatulating the ureter a little more than the usual. So in this case, if there is any adynamic segment, it will go up towards the apex of the pelvic resection site or the anastomosis. So the area of the major anastomosis will not be having any adynamic segment, hopefully. So this is the apex of that segment of the ureter. Now is the area of the pelvis. The difficult part of the anastomosis is already over. Now is the easy part. One can continue to go towards finishing of the anastomosis with the same suture without tying. However, tying provides an extra strength. So we tie the apex suture so that there is no tension on the rest of the pelvis. So now only a few stitches will be required, and these stitches do not usually need any fine work. It is just opposing the two walls to each other. So talking of the principles here, you can see that the vascularity is well maintained of the ureter as well as of the pelvis. Number one. Number two, the anastomosis is not under tension. You can see the ureter is lying relaxed and the pelvis is lying relaxed. So if there is any disparity, try to not to mobilize the ureter for more than 5 centimeters. Any further mobilization will lead to devascularization. In that case, try to mobilize the pelvis because it draws its supply from the kidney as well. Or you can mobilize the kidney, and in laparoscopic procedure, mobilization of the kidney is easy. So, anastomosis without tension. Then watertight, you can very clearly see that the anastomosis is clearly watertight. And the anastomosis is at the dependent area of the pelvis. We have also reduced the redundant pelvis, and for free drainage we have placed a degestant. And thank you for watching the procedure.